The Eastern Cape is finally emerging from the second COVID wave, and medical staff are reeling, exhausted and emotionally drained. Dr. Afiq Eli has been working in the Frere Hospital COVID ward in East London since last May, when the first COVID wave peaked. He says the second wave was far worse.
We admitted about between 40 and 50 patients who were tested COVID positive over a 24-hour period. Sometimes our casualty area looked like a bomb exploded.
It's been no better in the private health sector. Dr. Mike Webb was treating 200 patients between the 3 life hospitals in East London.
It's incredibly taxing, emotionally, physically. Somebody called it a war zone today. That feeling of, out of control.
You expect private care to be a level up, but not always.
This pandemic has changed everything. I think the idea that just because you've got a medical aid, even money, doesn't get you into an ICU.
And for rural clinics like Madwaleni on the Wild Coast, at the end of a dirt road, the buck stops here. After 7 years, Dr. John D. Lotz knows December is a tough time when people return to their rural homes. And this December was grim.
We don't have the option of referring out to an ICU or a high care setting either. So that makes it really hard on our patients, hard on our healthcare workers, especially our nurses here, spending the majority of their time with the patients.
The situation at hospitals like Frere changes from day to day. At times, beds and oxygen devices are available, but often life and death decisions have to be made, with age and comorbidities decreasing your chance of being at the front of the queue.
I often caught myself thinking that I'm in a situation where I have to make death decisions instead of treatment decisions. And that part of dealing with COVID has been quite demoralizing.
The second wave has been so severe that it's caused an oxygen shortage around the country. Here at Frere Hospital, they're using about 5 tons of oxygen a day, up to 6 in December. Before COVID, it was around a third of that amount.
The problem is that COVID has got a pathological process that involves the lungs, and it reduces the lungs' ability to move oxygen to make it available to the tissues for perfusion. So we give extra oxygen to overcome the pathology caused by COVID.
Afrox, the major oxygen supplier to state hospitals, is running out of oxygen across the country. They've diverted supplies from their industrial customers to meet the demand.
For every patient on a face mask, you need 3 of those massive cylinders per day. During the peak in November, December, we had about up to 30, 35 patients in the ward. So if we use up all the oxygen on COVID patients, the rest of the hospital suffers as well.
Rural hospitals are the hardest hit when it comes to oxygen. Some are dependent on trucks to deliver the cylinders. At times, stocks run so low they have to borrow from each other.
The depot and Mthatha regularly struggle with transport issues, so they are only able to deliver to us probably once every 2 weeks or so. And when they do, they can drop off about 40 or 60 cylinders of oxygen at a time. And it feels like Christmas when they do arrive. But failing that, we have to use hospital buckies to trek to Mthatha and back on a twice daily basis.
Doctors are having to do the maths before making treatment decisions. If a critical patient needs 8 of the 20 oxygen cylinders on hand with only a 1/3 chance of survival, who gets the oxygen? The pregnant woman, the premature baby, or the 45-year-old man?
So we start getting into the realm of ethics and distributive justice. Who do we justify giving that oxygen to?
It's exactly these nightmare decisions that Dr. Craig Parker knows intimately, having done his community service at the oldest district hospital, Victoria, just outside Alice. What is unique about Dr. Parker is he started out as a mechanical engineer, became a doctor in his mid-40s, now working in anaesthetics at East London's Frere Provincial Hospital.
When it came to coronavirus and the pandemic unfolding around us, I felt that we needed a unique South African solution to the problem. Something that used very little oxygen, needed to be affordable, and it also needed to be able to be used by the general nursing staff out there.
In strict lockdown, a Facebook post asking for some diving gear to experiment with kicked it all off. A team of young techies and designers with 3D printers responded, working over Zoom and dropping off parts they developed in each other's postboxes. Within 7 days, they had the first design for OxERA, the oxygen-efficient respiratory aid.
I've been involved in most of the projects in South Africa around developing ventilators in one form or another. And they're full of people with good intentions, the right heart, most of them engineers. And so few of those have actually been able to deliver anything meaningful. So
Why is that?
The doctors on the ground, we knew ventilators was not what we needed. It wasn't going to fix it. And so there's often a disconnect between engineering and medicine. And I guess having done both, it allows me to bridge them a little more naturally.
OxERA has filled a gap between basic oxygen therapy with an oxygen mask and high-end care like ventilators. Its simple design belies its genius. An inflatable room fits tightly around the face, stopping valuable oxygen from escaping, which happens with normal masks. A pressure valve keeps the lungs from collapsing, and a filter stops virus transmission. Using only 15 liters a minute, working off cylinders or piped oxygen. The reason it's a game changer is that OxERA extends the range of therapy available at a basic facility, preventing the need for high-end oxygen therapy, which uses 60 liters a minute.
We just realized how amazing they are for two reasons. The first was that they use as much oxygen as a face mask. I didn't need to make an ethical decision to change onto OxERA mask. I could just provide it. And the second reason is that it seemed to perform about as well as our CPAP devices or our high-flow nasal prong. And suddenly we realized that we could kind of fulfill both needs. We could step up care for people without it costing oxygen for other patients. And filling that gap is amazing.
I had a patient come to my ward, an elderly gentleman, multiple comorbidities, obese. They were wheeling him into the ward, and I said, oh my God, but this guy's busy dying. His oxygen saturation is about 20%. And I applied the device, and within half an hour, his saturation improved to 97%. I mean, 8 days later, the same patient I thought was dying in front of my eyes was actually discharged from hospital.
All the doctors are clear that these are only anecdotal observations. Clinical trials began at Baragwanath Hospital as soon as the South African Health Products Regulatory Authority licensed it in late December. But for doctors on the front line, faced with insufficient ICU beds and nursing staff, it's been a lifesaver. Mike Webb immediately went out and got 20 devices for his private patients.
It buys you time in those patients that need support to get them through 24, 48, 72 hours until an ICU bed opens and you can get them in.
Vanessa Fisher is Dr. Webb's patient. Admitted just after Christmas to Life Beacon Bay, her oxygen saturation levels were critically low. And the longer she remained like that, the more tissue damage.
I remember saying to her that if we don't make a plan to get her oxygen levels up, she was going to be in very deep trouble and quite possibly die.
Vanessa, what was it like wearing that mask?
You almost have an anxiety attack because you just can't do anything but have this thing on your face. I kept telling myself, it's your job to breathe, that's all you have to do.
Do you think this device actually helped save your life?
100% yes. If it hadn't been for that OxERA mask, I don't think that I'd be here speaking to you now.
Craig's established a social enterprise, Umoyo, ploughing any profits into subsidizing or sponsoring the device, donating over 600 masks to rural and tertiary hospitals, turning this home into an assembly line while waiting for the registration. As fast as they could put them together, they were flying out the door. Initially, Craig wanted everyone to be able to print their own OxERA, but realizing his open source design needed support, they partnered with Rainer Gabler of Gabler Medical, who produce 15,000 a week.
It's a positive message for local manufacture of medical devices in this country, because I think it's been pretty obvious during the COVID crisis that we actually have a shortage of local manufacturers. Success stories like this one should encourage other designers and other developers to enter the medical device manufacturing field.
Doctor, if you could speak to the health minister right now, would you try and speed up the process of getting OxERA delivered around the country?
I would literally beg to see OxERA available. I would take this device and carry it in my bag as an emergency device.
A lot of pressure from the ground up saying, please, we need these, we need them as soon as we can, please hurry up with that process. So we're working as best we can with government to get that loop closed so that these can be put in the hands of the patients who need them.
Considering that half of South Africa's population is rural and the vaccine is a way off, Craig and his team have given healthcare workers another arrow in their quiver. in a resource-constrained country.
You know, when we get those reports back that your device saved another life, it's phenomenal.